So we have addressed some specific points. First of all was the imaging, and with imaging it is ultrasound. Ultrasound is a massive, it's a huge key point in this patient's care, so that not everybody has to have an expensive MRI or CT. And then as soon as you have an ultrasound of high quality, you can then see whether these masses will be malignant or will be borderline or will be of lower risk, and then accordingly to indicate a more advanced imaging in order to complete the radiological staging. We talked about the sensitivity and specificity of CTs, of MRIs, of PET CTs, of all the new technologies now, especially with the diffusion weight MRs. I mean, we see now that the advances in imaging are massive, and the patients sometimes they get exposed to multiple imaging, which is also a financial burden apart from a burden to the patient. So what we try to do is a bit to stratify. Does one patient need to have and an ultrasound and a CT and a PET CT and an MRI? No. So we try to put them more in little pockets, who needs what, and what the specificity and sensitivity of that is. For example, to dictate operability, a single imaging modality alone cannot dictate operability, usually alone. It needs to be taken the whole clinical picture. Then we talk about tumor markers and algorithms and signatures. We talk about circulating tumor cells and whether they can play a role in the diagnosis. So it was a multi-aspects project.